All right. Thank you so much, everybody, for joining us today for Pathogenesis and Treatment of Chronic Inflammatory Conditions. We have Dr. Bruce Patterson with us today. He is an expert in the field and very excited to have him as a guest. He received his undergraduate training in molecular biology from the University of Michigan in Ann Arbor. He then received his MD at Northwestern University, followed by a residency in pathology. During the early stages of the AIDS epidemic, Dr. Patterson began investigating cellular reservoirs of HIV-1 using molecular and in situ cell-based technology patented in his laboratory and used today throughout the world. Dr. Patterson determined that enough HIV virus was present in infected individuals to count for the massive destruction of the immune system. This paradigm-altering work was published in Science in 1993 and featured in Scientific American, Rolling Stone, and on the Discovery Channel. Dr. Patterson has since authored an additional 150 manuscripts and book chapters focusing on single-cell biology and diagnostics. He was formerly an associate professor of pathology and infectious disease and a director of virology at Stanford University. And he currently serves as the CEO and founder of IncellDX, a growth stage company that has translated his research discoveries into state-of-the-art single-cell diagnostics in cancer, oncology, and infectious diseases, especially COVID and also Lyme disease. So really happy to have him with us here today. Now, obviously, everybody knows that the focus of this is chronic inflammatory conditions. So I'll start with a question to get you rolling here, Dr. Patterson, which is, can you explain some of these striking similarities that have been recently discovered between chronic Lyme disease, long COVID, ME/CFS, and many other chronic inflammatory conditions?
Yes, thanks, Noah, and I appreciate the time to be on your podcast. So, what was really interesting in the early days of COVID was, the fact that that patients with acute COVID were being supremely immunosuppressed by the SARS-CoV-2 virus, and we published that back in the early days of 2020. And, this immunosuppression really brought a lot of previous infections to the forefront. So, for instance, we were seeing reactivations of the chronic herpes family viruses, CMV, Epstein-Barr, herpes simplex, varicella, etc. And that's what led us to look for other agents that could have a chronic phase, a latent phase, what have you. And of course, the organisms that cause Lyme disease were definite candidates for that. And indeed, over time, as we started looking at these immune signatures in these various chronic inflammatory conditions, that's exactly what we found. And then on top of it, what's coming out more every day that is piggybacking off of the long COVID research and description of the symptoms is that, there's so many patients who present to their physicians with fatigue, brain fog, and post-exertional malaise who don't have long COVID. And turns out that they may have exacerbation of ME/CFS or chronic Lyme, and that's really where we started. And having a diagnostic that we developed using machine learning and AI allowed us to be able to distinguish between those chronic inflammatory diseases.
Now, I have a two-part follow-up question to that. The first is, you mentioned a couple of symptoms. Could you elaborate on some of the other main symptoms that you're seeing that are persisting among these various patient groups? And then secondly, you mentioned your diagnostic tools have been able to distinguish between what the root cause of those symptoms are. So I guess explain a little bit more about symptoms and then discuss how you've been able to distinguish between these patient groups.
Those are such great questions. I mean, the symptoms are something that, yeah, I think some groups have described as many as 200 different symptoms in long COVID, and I think that list of symptoms is entirely overlapped by chronic Lyme disease. And, beyond sort of the fatigue, brain fog, post-exertional malaise, joint and muscle pain, dysautonomia, which is, leads to sort of POTS or racing heartbeat. Hot, cold insensitivity is something that I see in our 43,000 plus patients. That includes Lyme, long COVID and ME/CFS. Hot and cold insensitivity is one of the first questions I ask. I mean, it's a window into the blood vessels, and so that's a predominant symptom. Headaches, migraines, tinnitus or ringing in the ears, peripheral neuropathy, which is numbness, tingling, muscle twitching, cognitive impairment, and as I've brought up a lot lately, anxiety and depression. And it's very interesting. We can get into this a little bit, but our diagnostic panel includes these inflammatory proteins, one of which is TNF alpha, or tumor necrosis factor alpha, which is a major chronic inflammatory protein that lowers serotonin levels. So, as I've mentioned in several talks, serotonin, obviously controlling, mood, anxiety, depression. They're saying, we can use Prozac for long COVID. Well, again, it's more or less a Band-Aid on a symptom when the underlying cause is chronic inflammation. And now we're starting to see research articles coming out on dysautonomia in Lyme, POTS in Lyme, anxiety and depression in chronic Lyme. And some of it may be just because you have a chronic condition, but I think a lot of it is because the chronic inflammation is lowering neurotransmitters that are responsible for mood.
Now, I wanted to briefly go back to the discussion of the panel and your diagnostic technology. Could you describe how you've been able to identify the underlying causes of these laundry list of conditions, which I'm sure many of the patients that are on this webinar have personally experienced?
Yeah, so it's a really interesting story that reads almost like a novel, but I happened to be in Shanghai, China, in the first week of January in 2020, when talking about immune profiles in cancer and cancer therapy, when somebody would start talking about this new infection that was ravaging Wuhan, which was the city I was supposed to go to next. And they showed an early paper on some of the inflammation in this patient, and it was obviously what people later described as a cytokine storm, and clearly it was vigorous activation of the innate immune system, which is driven by macrophages. So early on, I really felt that acute COVID was a macrophage disease, and truly that was a big part of it, especially in terms of the tissue damage. So we developed a biomarker panel with over 158 biomarkers, both cell-based and plasma-based biomarkers, that we started looking at these patients with acute COVID, and we followed up those patients post-infection, 30 days, 60 days, 90 days. And as much as these patients got better, got out of the hospitals, went home, by no stretch of the imagination was their immune system back to normal in many cases at 60 and 90 days. And, even though there was significant immune abnormalities, it just seemed different than the immune abnormalities in acute COVID. So what we did is we used machine learning and AI to go through those biomarkers and show that there was the quote long COVID, or long haulers as they're described during the day, signature. And we published that in early 2021, and that morphed into a panel of 14 biomarkers that we use to this day. And those 14 biomarkers, cytokines and chemokines, which represent 3 to 4 arms of the immune system, we've now used on all these other chronic inflammatory conditions, including chronic Lyme, ME/CFS, fibromyalgia, and found signatures, for those conditions as well. But one of the most important things was that as much as those 4 conditions are different and our algorithms help differentiate them, there was one commonality between all of them, and that was this endotheliitis or vascular inflammation that was evident as part of three of the markers in the panel. And surely enough, the vascular inflammation leading to vasodilatation was something that could account for many of the symptoms in long COVID, chronic Lyme, ME/CFS, and fibromyalgia, and now PANS, PANDAS, and other chronic inflammatory conditions. So we found this commonality in all those conditions and have directed therapy in a very precision manner towards those pathways.
Yeah, I think to your point earlier, finding that root cause rather than trying to attempt to band-aid a lot of these individualized symptoms is seemingly where you've had a lot of success. So that's awesome that you've been able to identify the diagnostic side of things with a couple of these inflammatory conditions that we've mentioned. But I've also, to my understanding, you've had success in actually treating and working with patients that have these conditions. Could you talk a little bit about the success that you've seen in patients with long COVID in terms of treatment, and then maybe how that could be applied to some of the other conditions that we've mentioned this evening?
Right. So, when we first found this signature and we first started treating long COVID, um, over 3 years ago now. It was, we were just looking at long COVID, and we, as much as 80 to 85% patients got better when we targeted this endotheliitis, there was some patients who did get better. So we started pulling those aside and looking at their immune signatures. And again, they were different. So we looked more in depth. So for instance, when we saw elevations at interleukin 8 and interleukin 13, we started looking at the literature, and surely enough, along with interferon gamma, those were common cytokines that were part of the pathogenesis of Lyme disease. So then we started reflex testing patients with those signatures for all the different tick-borne organisms, and sure enough, started finding patients who had essentially the immunosuppression of acute COVID caused exacerbations of chronic Lyme, because there was either the organisms were either inadequately or untreated because they didn't even know, or as we had preliminary evidence, there may be retention and persistence of some of the Lyme organism cell wall or peptidoglycan in these non-classical monocytes that we discovered in long COVID. And these non-classical monocytes have this propensity to bind to blood vessels through a protein called fractalkine. So sure enough, one of the similar pathogenic mechanisms of protein and antigen persistence that we found in long COVID is in play with chronic Lyme. And certainly there's been manuscripts that have described cell wall, Borrelia cell wall, Borrelia peptidoglycan in the fluids in Lyme arthritis. But there's no reasons why you wouldn't suspect that phagocytic cells like monocytes wouldn't be involved in terms of gobbling up that cell wall and then presenting it to the immune system for months, years, maybe even decades. So that's the premise that we're operating on right now. And like I said, the focus of our treatment is on this endotheliitis to really treat the underlying cause and the symptoms, as opposed to the Band-Aid approach.
Now, I understand if any of your protocol is hush hush under wraps. Definitely curious to see if you could dive a little bit more into what it entails, if you're able to. I did some background research on you prior to this, and I had read that you had developed, you and your team, a novel protocol that had treated hundreds of chronic illness sufferers and seen a lot of success. Could you share with myself and the patients on this webinar what some of the things you've utilized in your protocol?
Yeah, so we published it in February, so it's really not a secret, and we're now up to 18,000
Wow.
treated individuals, and encompassing long COVID, ME/CFS, chronic Lyme, etc. And all of them need to be treated relatively similar, but a little bit different. And that's why it's imperative to have a diagnostic that can separate all of those. And that's the focus of this paper we're about to submit next week. But the long and short of it is, as physicians, and I want to take it from the patient journey approach, because I think that's the most important thing. Because I think that's where things can be missed. Yeah, it's great to say, well, I knew this patient had Lyme, and you look back and you say, well, what symptoms do they have? But that's not how medicine operates. Medicine operates when a patient comes into your office and says, oh, I have debilitating fatigue, I have post-exertional malaise, I have headaches, I have brain fog. What's going on? And obviously, with all the media reports and the focus on long COVID, you'll get patients come in and say, doctor, I have long COVID. And you're like, well, tell me why you say that. And they'll describe the symptoms. And again, my approach is, well, those symptoms are very nonspecific. So that's where precision diagnostics come into play. You could call our diagnostic test a fatigue test, because frankly, everyone who comes in who has fatigue, brain fog, and post-exertional malaise is saying they have long COVID. Yet, 80-90% of the time they do. But you know what? We've picked up, like I've said earlier, so many patients who had Lyme who didn't even know it, or been exposed to tick-borne, organisms and didn't even know it. And how are they going to know it? The patient comes in for their yearly physical. They said, yeah, I've been a little tired. Got a little bit of joint muscle pain. It'd be easy to brush that off as something. And you certainly don't go directly to testing for Borrelia, Bartonella, Babesia on someone who comes in and says, I'm fatigued, right? But that's where having a test like ours that, is essentially say, well, do you have one of these four very prevalent conditions: long COVID, chronic Lyme, ME/CFS, fibromyalgia, etc., or not? I think that's the advantage, and as we'll see in the papers, of having what's called a high negative predictive value. It's almost more important to say you don't have something than it is to say you have something. And to say you don't have something is all predicated on what's called negative predictive value, which says, the test is negative. Your long hauler index is less than 1, for instance. Where are the chances that negative is a true negative? And with negative predictive values of 98%, 98 out of 100 times that negative is a true negative. So it's critical to have that piece of information, because even though they may share, endotheliitis and inflammation of the blood vessels, they may need anti-herpes medication if it's ME/CFS. They may need antibiotics if it's been an unrecognized infection with a tick-borne organism. So there's modifications of our protocol that are used depending on what our diagnostics shows. But clearly, our approach has been, we use an HIV drug called Maraviroc. It is not an antiviral. It's actually blocks a receptor called CCR5 that HIV uses to get into cells, but it has no, significant antiviral activity whatsoever. So I think it's a misnomer that, that people say, well, we're using an antiviral or we're using an antiretroviral on our patients. We're not. Maraviroc is actually an exquisite immune modulator by blocking CCR5. So, it tempers dysregulated immune system. The CCR5 CCL axis is all about directing immune cells to sites of inflammation. Sometimes that's good, sometimes that's bad. What we really aim to do is shut off the bad while maintaining the good. And it's an immune modulator, not a steroid. It is not immunosuppressive, and I cannot emphasize that enough. I have a slide that I use at a lot of conferences that shows this cycle of infection, inflammation, symptoms, treatment. Infection, inflammation, symptoms, treatment. And so, it's absolutely critical if there's a latent infection or residual infection or persistent infection, using steroids is just going to create this vicious cycle. And what we're really trying to do is break this vicious cycle of infection, inflammation, symptoms. So our paper that came out in February in Frontiers of Medicine was, we looked at treatment 20 patients or so with Maraviroc and statins who had long COVID. And yes, it was a small number, but all 5 symptom scores, fatigue, dysautonomia, neuro, cardiac, and shortness of breath, all 5 of those symptom scores went down statistically significantly with that combination of drugs for 6 to 12 weeks. But what was most important out of that paper was we were able to correlate improvement in the symptom scores with improvement, meaning lowering of certain inflammatory proteins, so that we knew which inflammatory proteins were responsible for which symptom. That was previously unheard of in chronic inflammation. So somebody can come in and say, well, I have fatigue. And I can say, well, fatigue is correlated very strongly with tumor necrosis factor alpha, TNF alpha, interleukin 2, and to a lesser extent, SCD40L, VEGF, but TNF alpha, interleukin 2, major drivers of fatigue. And so being able to say what inflammatory proteins are driving which symptoms allows us to target the inflammatory proteins. Well, TNF alpha and interleukin 6 are both made by activated monocyte macrophage lineage cells. So CCR5 cross-linking with Maraviroc decreases that pro-inflammatory phenotype of those monocytes macrophages and lowers IL-6 and TNF alpha. And again, TNF alpha contributing to low serotonin, contributing to anxiety and depression. You can see how this is all fitting together like puzzle pieces. If what the inflammatory markers are, how to target them, and what symptoms are they responsible for. And one of the biggest issues I see out there in the labs and in medicine is we're using standard labs to look at non-standard diseases. Okay, long COVID, chronic Lyme, ME/CFS, fibromyalgia, to some extent have been mysteries and remain mysteries. Yet we use, the same CRP and SED rate for generalized information that gives us no information whatsoever in terms of what's going on. And so these patients come back from physicians' offices or labs, and they're like, everything was normal. Well, everything was normal because you weren't looking for what was abnormal, right? So that's kind of how we've integrated the use of our therapeutics and our diagnostic and being able to do data analytics on the data coming from our diagnostic, meaning machine learning and AI, has been the absolute key in drug discovery and saying what drugs are going to target this abnormality.
So I have one more question before I open it up to audience Q&A. I already see some questions coming into the Q&A section, but my follow-up to everything you just said, which is really amazing how much progress you and Incel DX have made. Obviously, you're educating and doing your best to educate people. You're coming on these type of programs, you're publishing papers. I met you at the ILADS conference, and obviously that's a direct conversation with hundreds of doctors to try to get them in line with the work that you're doing. But what do you see as next steps for getting your diagnostic and treatment modalities, I guess, accepted on a national scale?
Well, I think that's a great point. And, the fact is, we've been out for 2.5, 3 years and have an overwhelming amount of data, which we continue to publish. But the one major thing is our randomized controlled clinical trial that's been submitted to the FDA. Will be starting in early 2024 on this drug combination of Maraviroc and atorvastatin for the endotheliitis and of long COVID, and really will recapitulate the data we saw in the paper published in February, which we followed up with 314 patients on Maraviroc and statins after that to show highly significant reduction in biomarkers using this drug combination. So we're confident about this trial. We've got an amazing team on board. We've got trial sites that are being set up as we speak. Which we'll announce probably right around the first of the year. That is going to be I think the trial and obviously the forum that puts this on a much larger map. Although I would argue that we're already in Europe, UK, United States. I mean, we've been doing this and actively working towards the clinical trial. We're not on the media circuit necessarily, but we will be. And again, that's all PR anyway. But yeah, we're doing what we need to do. We're following regulations. We're submitting our drug. We're submitting our diagnostic. We're going through all the proper channels to get this out in the right way.
Well, and I think to your point, something that sets everything you've talked about over the past 30 minutes aside from several other doctors I've interviewed is the sheer number of patients that you've worked with and seen success in. That's a big sample size compared to a lot of other treatment protocols that are currently kind of being studied. So I hope that leads to, as I mentioned, a nationwide acceptance of this protocol, and we really see an opportunity for many patients who are suffering with these chronic inflammatory conditions to have some sort of a clear answer and way to resolve, what they've been dealing with for so long. So thank you so much for all of the information that you've shared to this point. Like I mentioned, I have a bunch of questions in now, so I'll work through them quickly, try to get the ones that are related to this specifically. And the first one that I see, I actually was going to ask you separate anyway. So when I send this information out to everybody who registered, somebody asked, could we get a link to the paper from that was published in February?
Well, so all the links are on our website for our chronic COVID treatment center, and obviously the CCTC also involves chronic Lyme, ME/CFS, etc. We're well into our second year with the CCTC. The web address is www.covidlonghaulers.com. All of our publications are there. All of our pertinent information is there. A lot of our interviews are there. A lot of our podcasts are there. So it's a great resource to find all of this information.
Awesome. I thank you so much. I'll make sure to include that in the recap email to everybody who's signed up. I think that, yeah, having the links to those papers are really good for people who want to further educate themselves about the specifics that you might not have had time to dig into. So sounds good. Let's see. Somebody had asked earlier in the presentation, so this would kind of be a step back here, but I think it is a relevant question. You had mentioned hot, cold symptoms and blood vessel issues. Could you explain a little bit further, since small blood vessel issues and long COVID have garnered attention? What manifestations of this have you seen in other inflammatory diseases?
Well, it's not just small blood vessels. It's major blood vessels because it's blood vessels controlling blood pressure. And when you have vascular inflammation, the blood vessels dilate. You can drop your blood pressure. Of course, when your blood pressure drops, your heart rate goes up. So, there's your POTS. The dysautonomia obviously contributes to that as well. We showed in the paper in February that the dysautonomia score, the Compass 31, went down statistically significant with our drug combination. So, there's so much that is associated with blood vessel inflammation. Like I said, headaches, migraines, brain fog, tinnitus, hot cold insensitivity, POTS. So, it's amazing when you relieve the inflammation, how many of those symptoms get much better or even go away.
So I think a good follow-up to this question came in about a minute or two after during your presentation was, do you believe that the chronic symptoms caused by Lyme or COVID are due more to the damage associated with molecular patterns or the constant activation of innate immunity?
Well, I think because we see a predominance of interleukin-6 and TNF alpha, I do think there's still engagement of the innate immune response, even though adaptive immunity has had plenty of time to engage. But I think it's the antigen persistence through monocyte macrophage lineage cells that have really led to this continuous exposure to whatever pathogen may have been there. And it may be a new mechanism besides true latency, which we see in the chronic herpes family viruses, and then HIV has its own mechanism of latency by integrating into DNA. Those are truly latent infections that can be reactivated. And then with Borrelia and some of the Lyme organisms, there's been discussions about biofilms. As a pathologist, I would love to see a slide of a biofilm, not made in vitro. But like I said, we have some preliminary evidence that there may be retention of Borrelia cell wall in monocyte macrophage lineage cells, which again, just like we found in long COVID and the S1, could be presenting antigen for months, if not years, after infection. So, I think all of those are in play. I think it's more hyper activation of the immune system as opposed to any kind of molecular changes.
Since you mentioned the cell wall fragments, you and our patients are really kind of plugged in together here. A follow-up question would be, would you or will your approach recognize that chronic Lyme patients have had actual spirochetes detected after extensive treatment, not just cell wall fragments?
Well, again, I've always made the point with viruses that just because there's viral persistence of RNA, DNA, or proteins, that doesn't necessarily mean replication competence. So, yeah, I think it remains to be seen just how long replication competent Lyme organisms stay in the body. Surely, when they've gone undiagnosed and maybe reactivated during the immunosuppression of acute COVID, I'm sure those patients still have bugs somewhere. But like I said, I'm also very focused on chronicity of these infections. and the possibility that mere fragments of the bugs can continue to do damage by being presented to the immune system for long, long periods of time in the absence of true latency or in the absence of replication competent organisms.
Thank you so much. This is not a question, but somebody put in here that they were a part of, they wanted to say that they are better from their debilitating long COVID due to your group and supplements. So thank you so much. Wanted to at least, share that information with you. A quick follow-up question about your trials is, how can somebody become a part of your clinical trial?
Yeah, so the best thing to do is to register at www.covidlonghaulers.com, because of course the first thing we have over 43,000 individuals registered. Of course, the first thing we're going to do for trial recruiting is basically send out an email blast and say, here are our trial sites, and go from there. I mean, that's I think that's probably the best way, and I think it's been a really important way to keep in touch with our patient base.
So for everybody who's here now, I'm going to go ahead and drop the link in the chat. I think that'll just be easier. You've mentioned it twice, so I think that there's a lot of information that can be found there. I will also make sure to include it for the email blast that I send out to everybody who is registered, but just for those who are actively here, click that link and it seems like you should be able to get a lot of the answers that are rolling in here. So I saw a couple of people actually in this Q&A session asking about how to enroll in clinical trials. So hopefully you get a couple of people from this session.
And just so everybody knows, we won't stop at long COVID with the trial. We will. We've had a lot of discussions about moving quickly onto chronic Lyme and treatment of chronic Lyme in a randomized clinical trial after we do our long COVID trial. So we are not going to leave the Lyme group out there for very long.
And do you have any planned age range or other factors that you're going to lead into these trials, or it's going to be really open?
No, once we announce, we'll announce age range and entry criteria, but we don't really, we haven't contemplated excluding any age range since these conditions affect everybody. And I think one of the most important things is, we're starting to get reimbursement for patients for the diagnostic and of course reimbursement for the telemedicine visits. So I think those are all key aspects for us to be able to reach the greatest number of patients possible. And I know, coming out, it was, those things weren't in place, but now they are. They're more, we're improving our ability to reach more people every single day. And I think that's the most important thing of what we're doing right now.
Awesome. Thank you. I think that's a good place to stop. I apologize for anybody whose question we can't get to. Some of them may not apply specifically to this recording or etc. But thank you all for attending. Thank you all for your interest and for providing questions in this session. Thank you so much, Dr. Patterson, for taking the time to educate us on all the great work that you're doing. We will definitely be promoting this out to our entire patient community. So I hope you get a lot of people involved in your upcoming clinical trial. Wish you best of luck with your next publication that's coming out. And just thank you again for everything that you've done.
Appreciate it. Thank you so much. Yep.
Yeah. Have a great night. Bye-bye.